Okay, chapter 19, gram-positive bacilli. All right, so who are the gram-positive bacilli that are medically important that we should focus on? Well, to begin with, you need to understand that gram-positive bacilli may be divided into three major groups. Okay, and the key here is, are they an endospore? Do they have an endospore or not? And are they irregularly shaped, or do they stain odd or peculiar? So basically, are they endospore formers? Are they non-endospore formers? Or do they stain irregular? Those are the three major categories when we're thinking about bacillus. So what is an endospore? If that's one of the major determining features, what is an endospore? Well, it is a dense survival unit that develops in a vegetative cell. Remember, vegetative cells are normal when they're normally active. And this is what happens when a vegetative cell picks up that there is a nutrient deprivation, or the environment is starting to turn south or get bad. Basically, this organism will then go into this dense survival unit known as an endospore so that it can sustain the drought or the nutrient depletion or the environmental chaos. Now, it says right here that most endospore-forming bacteria are gram-positive. They are motile, which means what? That's right, they can move, and they are rod-shaped. The two major genus that you should focus on are Bacillus and Clostridium. Now, we know that these two genuses are resistant to heat, they're resistant to drying, they're resistant to radiation, chemicals. They happen to have a longevity. They can be dormant or in that endospore for a long period of time and then come back into the active vegetative state. We know that they serve particular ecological niches, which is basically they have certain jobs within the ecology. And we do know that they are pathogenic. So what would a endospore look like? Well, of course, here's a drawing on the left-hand side, but if you look on the right-hand side, you'll see these little spores in the center, and those are considered to be endospores. Okay, and then this is Clostridium. This is kind of showing you what the endospore would stain as. So when we look at these charts, of course, you know I love charts. It's talking about, just kind of giving you an idea of who the organism is, and then what body system would you typically, which body system would you typically see the issues. So for example, Bacillus anthracis, you typically are going to see in the skin and skeletal system, whereas if it's pulmonary, if it's in the respiratory, it's called pulmonary anthracis. So again, I think these charts are great. And they help to focus you on the individual organisms, and then who do they, or where do they typically cause problems. All right, so let's get to some general characteristics of bacillus. We know that they're gram-positive. We know that they're endospore forming. We know that they are motile. And then we know that they're mostly saprotropic, or saprobes. And what that means is that they're decomposers. Okay, so they help to break down other organisms. We know that they are aerobic, which means that they need oxygen. We know that they are catalase positive, which means that they are able to break things down and give off oxygen. We'll learn about that later, but they're catalase positive. We know that they are important because they're saprobes. They're important for degrading or breaking down large complex macromolecules into smaller molecules. We know that both of these genuses or genera are important for making antibiotics. We know that they're found in soil. Okay, and the two species that we need to concentrate on for medical importance is Bacillus anthracis and Bacillus cereus. And obviously one, anthrax, can be very problematic, and then cereus typically is food poisoning. All right, so let's concentrate first on Bacillus anthracis. These are large, block-shaped, angular, non-motile rods. We do see the endospore in them when they're stained. And we know that these are very virulent, which means that they are able to sustain harsh conditions. We know that they give off exotoxins, and those exotoxins, again, are seen in gram-positives typically, but these exotoxins can often cause edema, swelling, and can cause cell death. So, who are the three major types of anthrax? You have cutaneous anthrax, pulmonary anthrax, and gastrointestinal anthrax. So with by the way, and most of these come from the Middle East, Asia, Africa, and it's usually through livestock. Cutaneous is going to enter through the skin, thus the word cutaneous, and the typically what's going to happen is you're going to get a black sore. We call that an eschar. And the cutaneous anthrax of the three is the least dangerous. Pulmonary, on the other hand, is usually inhaled. It can be from animal products or from soil, or it can be used as a biochemical terrorism, can be used in biochemical terrorism. And so that would obviously affect the lungs. And then gastrointestinal is an ingested spore, and this is, of course, rare, very rare. Unfortunately, even though it's rare, it is often lethal. Okay, so I'm sorry. All right, so how would we treat anthrax? Well, typically you treat anthrax with clindamycin, doxycycline, or ciprofloxacin. Okay, so those are the big three: clindamycin, doxycycline, or ciprofloxacin. But the key here, and I think according to your objective, what's special about this treatment is that antibiotics are often given with a secondary drug, raxibacum. I can't even say it. Raxibacumab. But basically, it's given with a secondary drug, and the importance of that is that secondary drug will actually bind the toxin and prevent the toxin from then entering the cell. So that's kind of what's interesting about it. So you give the antibiotic, but you give it in combination with this other drug, a secondary drug, because that secondary drug actually binds the toxin while the primary antibiotic treats, to try to kill the actual microbe that's making you sick. As far as vaccines, vaccines go, you can do a live spore or a toxoid to protect livestock. We also know there's something called biothrax, which is a purified toxoid, and this is for high-risk occupations. Like this can be like for military, for doctors, nurses, medical personnel that may come in contact with those that are deployed. And it says the toxoid inoculation over 6 inoculations over 1.5 years, and then annual boosters to keep it up to date. So clearly, if you think about our military and where we, send our troops, that purified toxoid, that biothrax, is definitely recommended for possible exposure. Okay, Bacillus cereus. Now, Bacillus cereus is a common airborne and dustborne bacillus, bacteria. And notice that it says usual methods of disinfection and antisepsis are ineffective. Okay, great. So it's dustborne, it's airborne, and our usual cleaning mechanisms are not very effective. We know that Bacillus cereus can grow in foods. We know that the spores can survive cooking and reheating. And what will happen is that ingestion of this Bacillus cereus usually will cause nausea, vomiting, cramping, diarrhea. But the good news is it usually only lasts for 24 hours. No major treatment is given other than just, what we call supportive therapy. Make sure they hydrate, make sure you rest, things like this. But the problem would come in with your patients are people that are immunosuppressed. So all of us in here probably have had Bacillus cereus or been exposed to it at some time or another, food poisoning, and it runs its course, it runs through you, you get it out, and usually you're no worse for the wear, but again, we are immunocompetent, not compromised. All right, so what about the genus Clostridium? What about the genus Clostridium? Well, we know that these two are gram-positive. But these, instead of being aerobic, these are anaerobic and catalase negative. These are anaerobic and catalase negative. And so because they are anaerobic, notice it says spores produced only under anaerobic conditions. So these are then going to, if you think about it, kind of undergo like a fermentation or an anaerobic respiration. They're going to form organic acids, alcohols, and exotoxins. So typically we see this in terms of wounds, wound infections, tissue infections, and then food intoxications as well. So again, you see the spore in Clostridium just like you did with your bacillus. Okay, so Clostridium perfringens. This is the most frequent Clostridia found. Is typically going to be in your soft tissue or wound sites. It can be found in soil. It can be found on human skin, intestines, and vagina. So what are some factors that make you more susceptible to Clostridium perfringens? Things that make you more susceptible are obviously surgical incisions, compound fractures. Remember, compound means that the bone has actually punctured the skin, come out of the skin. Diabetic ulcers, septic abortions, puncture wounds, and gunshot wounds. So again, some of the things, the virulence factors that Clostridium perfringens has is they do have the alpha toxin, which causes the red blood cells to rupture, swell, and tissue to be destroyed. They have several enzymes that help them to break down collagen, DNA, etc. So they're going to have a lot of enzymes at their disposal that is going to help break down tissue. Now the two forms of gas gangrene, okay, so gas gangrene and myonecrosis are, number one, the anaerobic cellulitis, and this is where the bacteria spreads within damaged necrotic muscle tissue producing toxins and gas, but the infection remains localized. Okay, so it's bad cellulitis, but it typically can be treated and it stays localized. I'm sorry. True myonecrosis is much more destructive. It's much more extensive. It actually mimics necrotizing fasciitis. And what happens here is that the formation of the gases causes a lot more tissue destruction than you would see just in normal anaerobic cellulitis. So here's an example of gas gangrene or myonecrosis. So how can you prevent, how can you treat gangrene? Well, number one, immediate cleaning, okay, of dirty wounds. So think about that for just a minute, dirty wounds. So let's say you get a puncture. Let's say you get poked by, some barbed wire, or let's say that you get I hate to say a stab wound or some kind of puncture. Clean it out. Right? Think about it. The muscle's going to naturally kind of close back up on some of those small wounds, but you want to kind of open it up, boil it out, clean it out. Think about like hydrogen peroxide, alcohol, soap and water for that matter. The deeper the wound, the more you're going to be concerned, because you may not be able to reach the deepest, the depth that the puncture actually goes to. Compound fractures. Think about that. If you break a bone and the bone comes protruding through the skin and breaks, it's going to be susceptible to the ground or whatever it's come in contact with. So they're going to have to make sure they clean that compound fracture really good, clearly before they set it, and etc. And then an infected incision. Again, it's that being able to get to those deeper levels. Then, after you've done the immediate cleaning, you want to debride the tissue. So if there is any diseased tissue, necrotic tissue, you want to make sure that that tissue is cut out and removed. You then need to put the patient on large doses of cephalosporin or penicillin. Hyperbaric chambers are actually wonderful because think about it, oxygen chambers These are anaerobic bacteria, so they are not going to like the oxygen environment. So hyperbaric chambers are often beneficial for treatment of gangrene as well. And that's why, like for a lot of your diabetic patients, they find that if they can debride the wounds in the hyperbaric chamber, they may not lose the toe or the foot or the limb as readily as if they just did it the old-fashioned techniques. Please know that there are no vaccines available to prevent this. And this, of course, is showing a picture of a nurse in the hyperbaric chamber with, two patients. So again, we find that that high oxygen level, remember oxygen is toxic to anaerobic microbes. So again, trying to expose them to that is hopefully going to reduce the spread or reduce the proliferation of the microorganism. So let's look at this. Which of the following is a mode of transmission for Bacillus cereus? Is it inhalation, ingestion, entry through wounds, or sexual contact? Bacillus cereus. And hopefully you think Bacillus cereus, you think food poisoning. Therefore, ingestion would typically be the mode of transmission for this microbe. Okay, tetanus and lockjaw. Tetanus and lockjaw is a neuromuscular disease. It's often referred to as lockjaw because of the early effects of the disease. It is caused by Clostridium tetani. It's very common in soils, specifically cultivated soils, so farming soils, and it can be found in the gastrointestinal tracts of animals. Notice that it says spores usually enter through accidental puncture wounds, burns through the umbilicus, frostbite, and crushed body parts. It also is going to want anaerobic environment. Okay, so anaerobic, remember, so these are, in order to grow and to flourish, they do not want to be exposed to oxygen. So what is a tetanospasm? It is a neurotoxin that causes paralysis by binding to the motor nerve endings. So if we kind of think back to our anatomy classes and we think back to that neuromuscular junction, and remember how the acetylcholine, I'm going to get down in the next slide, how the acetylcholine is released and, all the 18 steps of muscle contraction. Well, basically, these tetanospasm block the release of the neurotransmitter that then allows the muscle contraction to stop or be inhibited. So what happens is that the muscles will contract and then stay contract or uncontrollably stay contracted. So death is usually from paralysis of respiratory muscle. So that inability to exhale, inhale, the movement of the diaphragm is usually what causes death in the case of tetanus. Most commonly found among geriatric patients, okay, so older patients. It can be found in IV drug users or abusers, that makes sense, puncture wounds. And then neonates, okay, and typically not in our country, but in developing or less developed countries, we see neonatal tetanus. And again, you see the rigidity of the infant. How do you treat it? Okay, again, you want to deter the degree of toxemia. So basically you want to try to keep it from spreading. There is a human tetanus immune globulin, and it inactivates circulating toxin but does not counteract what is already bound. So that's kind of, important. It controls infection with penicillin and tetracycline and then muscle relaxants. Okay, there is a vaccine available, right, tetanus, and you need a booster every 10 years. All right, C. diff, Clostridium difficile. Clostridial disease, most commonly called C. diff or CDI, is the second most common intestinal disease after salmonellosis in industrialized countries. Okay, so C. diff, second most common intestinal disease. Basically, it's caused by Clostridium difficile, a normal resident in the intestines that is normally in low numbers. The problem is that when you go to the hospital, so we often see these in like community acquired diarrhea. So think of it like nosocomial infections. We see it in the hospitals because think about it. When the patient is in the hospital, they're being put on high doses, usually of IV antibiotics. Well, this is going to kill the natural normal flora found in the guts of the patient, which is going to allow C. diff to then flourish and become very opportunistic. Treatment and prevention. So antibiotic-associated colitis, if you think about it, patients given usually broad-spectrum antibiotics kills off all the other bacteria and thus allows Clostridium to flourish. Mild cases, when you have mild cases of C. diff, fluid and electrolyte replacement, and then obviously stop giving the antimicrobials and give the body time to get itself back in check. More severe infections are going to be treated with oral vancomycin and then with replacement cultures. Image on the left is what a normal clean intestine, obviously this would be like after it's been cleansed, right? No fecal material in there, but then the one on the right actually shows the ulcerations and shows the formation of how the C. diff colonies are really flourishing. And of course, what's the one thing with C. diff? The smell, the smell, the smell. It's very intense. So, of the two Clostridium species that are involved in food poisoning, you have Clostridium botulinum and Clostridium perfringens. Botulinum is rare. Okay, it is rare, especially in developing countries. I mean, not developing, in developed countries, it's rare. But we could see it from home canned foods not being canned properly. And then Clostridium perfringens is a mild intestinal illness. It's the second most common form of food poisoning in the world. Botulism itself is intoxication associated with inadequate food preservation. And basically what happens is that the botulinum toxin is what's given off, it's what's released. So this is why we refer to it as intoxication. In other words, it's not the microbe or the bug that makes you sick, but what the bug gives off that typically makes you ill. Botulinum causes the NMJ, the neuromuscular junction, to block the release of acetylcholine, which is necessary for muscle contraction to occur. So typically the person is going to have doubled or blurred vision, difficulty swallowing, and neuromuscular symptoms. Okay. Infant botulism, same thing, except it's the most common type of botulism in the United States. Basically, they ingest the spores, and so then the baby will become flaccid, or maybe I should say more flaccid than it normally is, and this is called floppy baby syndrome. Wound botulism is going to be where the spores enter through a puncture wound or puncture wound and then cause food poisoning symptoms. So how do we treat it? Okay, basically determine the presence of the toxin by checking the intestinal contents or fecal material. Administer the antitoxin. Make sure you have cardiac and respiratory support for them. Treat it with penicillin, and then practice proper techniques for preserving foods, and make sure you know where you're getting your food materials from. All right. Clostridium perfringens is gastroenteritis. Again, it basically causes the epithelial cells of the intestines to slough off. It's going to cause diarrhea. It's going to cause acute abdominal pain, nausea. Typically, you're going to have rapid recovery, 24 hours or so. Of course, you think you're dying, but you're really not. So here are the spore-forming pathogens. Again, it kind of gives you the species. It tells you whether it has oxygen requirements, meaning is it aerobic, anaerobic, facultative. It tells you treatment, and it tells you what diseases are caused. So the act of the botulinum toxin is on what? The spinal nerve, the cerebellum, or the neuromuscular junction or smooth muscle. And hopefully you said the neuromuscular junction. Alright, I'm going to stop here and then I'll finish up with the rest.